Okay, so here's where we left off on the STEMI lecture, and we had one last little bit, which is about right ventricular MIs and posterior MIs. And there are two areas of possible infarction. That a standard 12 lead does not have electrodes facing the right part of the heart, and those are right ventricular or right-sided, that's the same thing. And a posterior, meaning the posterior wall of the heart. So a right ventricular MI, by the way, I don't care if you call it a right-sided MI or right ventricular MI. You should be aware that the abbreviation a lot of times that you will see is RVMI. Okay, and that's why I'll say right ventricular MI, so you'll recognize that. If you're reading something and they start talking about an RVMI and you're thinking, what's that? That's what it is, okay? So rarely an isolated event. It's very rare to have just the right side infarct without the inferior wall. Why is that, by the way? Based on what you know, which arteries perfuse the right side and the inferior wall? Yeah, right coronary artery and sometimes the left circumflex. But the right coronary artery, remember the right coronary artery circles around to the back and then drops down. So, and about a third, so 30% of inferior STEMIs have a right-sided involvement. So it's a lot. Okay. The right-sided MI, or the right ventricular MI, doesn't show up as ST elevation on a normal ECG because all of the electrodes are on the left side. So you just don't see it. Okay. So now, it depends on your protocol. This particular slide refers to a particular protocol. But you might not necessarily work under that. I will tell you now that as far as I know, I think, say, Maltco, what they do is once you have an inferior MI, they assume that there's probably right-sided involvement, or there's a good chance of right-sided involvement, and they don't move the leads. And we'll talk about, in a minute, we'll talk about why the advantages of moving the leads and not moving the leads. But if you work under a protocol, and in my class, I'm going to assume that the protocol you work under is to move the leads, okay? And you may not, you might just work under something like Maltco. If you see an inferior STEMI, move leads V4 to the exact position on the right side, okay? So where it is on the left side, you move over to the right side. Some people will move V4, V5, V6, but it seems like even very conscientious, good, knowledgeable people will just move V4. So I think that's just totally fine to move just V4, okay? And then you do another 12 lead. Now, if it's a hospital 12 lead, you can actually have its own separate line that says, in a minute, we'll actually see a 12 lead, a hospital 12 lead, where the additional V4R, V4 right, has been added on. But for a pre-hospital 12 lead, when you move it over, when you print it out, it's still going to say V4 because the pre-hospital 12 lead doesn't have the ability to print out V4R, which is what it is, V4 right, which means you, when you print out that 12 lead, have to write it in. And you'll see people write V4R over the top of the printed V4. So you just have to keep track. And then what you're looking for is ST elevation. So if you've got the inferior STEMI and then ST elevation in V4, or V4 through V6, you've got a right-sided STEMI. Okay, does that all make sense to people? Now, when you're looking at a regular 12 lead, not one where you've moved the leads aside, but just a regular plain old 12 lead, there's some things that can tell you maybe there's a right-sided MI. The first one, of course, is inferior STEMI. Okay, and Koa, what do you expect to see with an inferior STEMI? Which leads?
2, 3 in AVO.
And where would you see reciprocal changes?
1 in AVO.
Yeah, okay. So you're looking at the 12 lead. It's got ST elevation in 2-3 AVF, maybe reciprocal changes, and 1 in AVL, and you say inferior stemming. At this point, you should suspect a right-sided. Before you actually move V4 over, if you remember to do it, you can look at V1 and V2, and if there is a right-sided, the chances are pretty good. You're going to see ST elevation in V1 and possibly ST depression in V2, okay? And if you see that combination with an inferior, you know, you can make a bet with your partner and say, oh, I bet there's a right-sided, and there probably will be. Now, if you're going to move it anyway, this isn't so important, but it's good to know so you recognize what it means, okay? Yeah.
The elevation and depression in V1 and V2, that's in conjunction with the inferior
Yes,
stemming?
yes, yes. Yeah, and I'll just leave it there. That being said, you will see, occasionally you'll see a 12 lead, maybe not without an inferior stemming that just has ST elevation in V1.
Mhm.
If you just have ST elevation in V1, it's meaningless.
Okay.
Okay, just so you know that. If it's in V1, V2, V3, V4, it's not meaningless. Okay. Now, a right ventricular MI, right-sided MI, is a special situation because we alter our normal treatment. What do we do differently?
No nitro.
And why not?
Because you dropped the preload.
Yeah, it really drops the preload. We're going to talk in a minute. Perhaps you already know why it's such a big deal, okay? Let's see, I must have it here. So, who remembers Starling's law of the heart? What is this?
I do remember it. I just don't remember the exact words. So it's the farther the pericardium stretches, the
Not the
more powerful the
pericardium.
subsequent contraction. Or?
You're like talking all around.
Yep, I-
So,
yeah.
okay, so the more the myocardium is stretched.
Myocard,
Yeah,
not pericardium.
the more the
Yeah.
myocardium is stretched, the harder the contraction, okay? The right ventricle, what's the difference? If you were looking at if you were doing a dissection, so Riley, if you were doing a dissection and you had the heart, you pulled it out, and maybe slice it open, who knows? And you're looking at it, will you be able to tell the left ventricle from the right ventricle?
I think so. I think it was, the right ventricle is a little smaller, or is it less muscle?
Yeah, it's would be. So yeah, and the left ventricle has much thicker myocardium. So what we say is even a healthy right ventricle is preload dependent, okay? It's preload dependent. And what that means is it needs that good preload to have a good stretch. Now the left ventricle also likes to have a nice preload, but it's more muscular. So even if it doesn't have a great preload, it can still do a better contraction. So again, even under normal conditions, the right ventricle really likes to have that preload so it has a stretch so it can do a good contraction. However, when the right ventricle is infarcting and it's struggling to pump blood, it really needs that preload in order to get to be able to pump effectively. And what does nitro do to the preload?
Decreases it.
Say it again?
Decreases the preload.
Why?
Because it vasodilates.
Mm-hmm. Okay, so we're creating more of a reserve prior to the cardiac, prior to the heart. So less blood is going into the heart, less preload. And if the right ventricle, which really likes a good preload, but now not on top of that, it's infarcting, then you're really going to create a problem if you drop the preload. Okay. And if you've heard of, has anybody in the field heard about these patients that you give nitro to and they drop 30 points or something like that? It's very dramatic. It doesn't happen very often, but if it does, it's probably because they have a right-sided. Okay. So for that reason, we simply withhold nitro if you know there's a right-sided. Now, and in this class, that when we talk about change of treatment, we'll say that's our protocol. But if you work in a place like Malco, what they say is, well, I don't want to take the time to move the right side, the electrode over. So we're just not going to give any nitro to anybody who has an inferior STEMI. So that's how they do it there. It's not worth it, okay? The time isn't worth it, okay? But in this class, we're going to say you work, just so that when I ask you the question, should you check for a right-sided MI, I am assuming you're working under a protocol where you do check for a right-sided MI, meaning you move V4 over, okay? So, what's the answer to the question? When do you check for a right-sided MI? What do you see on the 12 lead?
If you have an inferior.
Yeah, it's very simple. You have an inferior STEMI, that question I have on the bottom of the STEMI homework, should I check for a right-sided MI? If you have an inferior, answer is yes. If you don't have an inferior, the answer is no. It's very straightforward, okay? Okay, so here we can see we have our inferior STEMI, we have ST elevation in 3 in AVF, and maybe not, tiny bit in 2, but we also have good reciprocal changes in 1 in AVL. So we move V4 over. Now, if this was a hospital lead, you would do a second 12 lead and you would write, write in with your pen V4R, but this is a hospital 12 lead, so they can add it, okay? So, is there right-sided? Yeah, okay, because we've got ST elevation. Okay, and here's our pre-hospital one. Again, here we have our criteria for, do I put down? Yeah, I did put down. Oops, excuse me. So we've got ST elevation in 3 in AVF, reciprocal changes in AVL, TAD in 1. And so in this particular case, the paramedics moved V4 over. And I don't know how they printed that, to be honest. I've always just written it. Maybe they had a nice little stamp. I don't know. Anyway, V4R, they printed it on. And again, yes, we do have a right-sided. Okay? Oh, and here's the... Oh, they moved both over. Excuse me, I didn't see that. So V3R and V4, they moved 2 over. Okay? Okay. And this is another thing you can do. Like, if you believe you have a right-sided STEMI, withhold nitro, but sometimes it's really helpful for that person to give, I'm not talking about like flooding them with fluids, but maybe 100 milliliters, 100 cc's, 150, 200, something like that. Just a little fluid bolus, and that tends to help, again, because you're adding a little bit of preload. So question about right ventricular MI. Okay, yes?
My protocols say that you can't think about opioid analgesia for chest pain until after you've given 3 nitros, but obviously it's contraindicated for these patients. How do you feel about just skipping straight to opioids?
Okay. I would say yes, particularly if it's fentanyl, because fentanyl, again, neither, whereas, let's think about the reasons for it. It's true that particularly morphine does have some vasodilatory effect, not nearly as much as nitro. And it can drop the blood pressure, but not nearly as much. It's not a great vasodilator. And so, I, of course, ask your preceptor or your medical director, don't pay attention to what I say. But I worked in an area where we never gave nitro for right-sided, and we did check. And at that point, we didn't have fentanyl, but I would give morphine. Okay? And fentanyl even more so because it has, there's very little problem there. Okay? I'll leave it at that. So, okay. Posterior. Oh, posterior. There we go. So there are no leads to directly visualize the posterior wall in a regular 12 lead. If you do want to add leads, in fact, has anybody heard of a 15 lead? They do them in the hospital sometime. Anybody seen it done? They actually they have 3 more leads, and they simply put them along the inferior edge of the scapula. That's where it would be like V13, V14, and V15. So, no, that's not right, excuse me, V7, V8, V9, sorry. If we want to do that, you would take 4, 5, and 6 and move it along the back to create V7, V8, V9, okay? And we're going to talk about whether it's a good idea to do it or not, okay? However, so we can't, on a regular 12 lead, we can't say for sure, because we don't have ST elevation, that there's a posterior STEMI. But if you see ST depression in V1, V2 may be extended into V3 and V4, you should have especially in conjunction with an inferior, you should have a high index of suspicion for a posterior. Why? What is the
It'd be the reciprocal change.
Bingo, it's the reciprocal changes. When you have, let's say there is a posterior STEMI, so if you put leads along the back, you're going to see ST elevation. Where the reciprocal changes are V1, V2, sometimes extending to V3, V4, okay? So it doesn't confirm, it's not having ST elevation in V1 and V2 is not enough to confirm a STEMI, but it's enough to suspect a STEMI, okay? So V1 and V2 are the reciprocal leads of the posterior leads. So if you have, in this case, they put 4 along the back, so V7, 8, 9, and V10, and then V1 and V2, what you're going to see here is ST elevation, possibly a flipped T wave, possibly a Q wave. What you will see in V1 and V2 is ST depression, which is the reciprocal change to the elevation, possibly an upright T, possibly a big R wave, which is the reflection of a Q wave if it's there. But the most important one is the depression, okay, in V1 and V2. A posterior acute MI is most often seen with an inferior, an inferolateral, or a lateral STEMI, not nearly as common. It's these two, which typically are with a posterior. Anybody know why? Really the same answer as the right-sided. Why do we see, what does it say again?
Same artery.
Yeah, and in this case, again, remember the inferior STEMIs and the inferior laterals. The inferior laterals are probably left circumflex. This one could be either RCA or LCX. So if we look at right coronary artery, left circumflex, they both circle around the back. Okay, and this is the back. This is the posterior wall. You can see it, and they drop down. And a lot of times the posterior, and you don't have to, like I said, you really only need to know the arteries I already told you, but a lot of times the posteriors have to do with the posterior interventricular artery, okay? Don't need to remember that part. So 80% of posterior MIs, acute MIs, are caused by a blockage in the right coronary artery and 20% by blockage in the left circumflex. So, just to summarize that, V1 and V2, and sometimes V3 and V4 as well, are the reciprocal leads of the posterior leads, V7, 8, 9. Again, another picture of that. You can see they're just directly across from each other. So, what you're going to see if you do the posterior leads, again, this is just repeating, you're going to see ST elevation, possible flip T, possible Q. And how that shows up on the septal leads is ST depression, positive T wave, and large R. Again, the ST depression is the most important. One more time. Okay. So, in ECG changes in the septal anterior leads, I guess I thought it was really important, only provide evidence for a possible posterior, okay? But really, the only way to confirm is to move the electrodes around the back. And in order to do this, a 15 lead ECG is needed with V789. And some EMS systems are beginning to carry these. I don't know of anybody around here who does, but apparently that's the case. So we are interested again in 3 specific ECG changes, and this is in order of importance. The most important is ST depression. The second is large R waves, and then only when it's in conjunction with these, the upright T. Now this slide is where you get to think, that's the most ridiculous thing I've ever heard. But I'm going to put it out here because every once in a while it's useful to somebody. Okay, I got it from a reference that they thought that it was helpful for people who are learning about posterior STEMIs like you, that this looks like this, which they called a circus pony. I call it like a carousel pony. Anyway, so they said, oh, all you have to do is remember circus ponies, and then this will come to mind, and then you'll remember. Okay? See? That's the reaction of everybody. But every once in a while, I get a student, when we're practicing, they'll go, oh, and then I see circus ponies in V1 and V2. So that's why I've never dumped out this slide, because it apparently does help.
Say now, I'll never forget it.
Yeah, see? See?
Circus pony.
Yeah, yeah. Yeah, don't do it to your preceptor. And they said, oh, you know Garcia as well. Again, that being said, what is important here is that, listen to this, ST depression in V1, V2, possibly V3, V4, by itself, without a large R wave, without an upright T, is enough, but with an inferior STEMI, is enough to suspect a posterior. A large R wave in those leads, V1 and V2, is sort of enough. That's the only way I can put it. Is sort of enough to suspect a posterior STEMI. Upright T's by themselves with no ST depression, no large R waves, not important. Okay? So the combination of the 3 is important, but I really want to emphasize it's the ST depression that is the most important. Okay? Now, here's the thing is we don't change our treatment with a posterior STEMI. Okay? So for that reason, I don't know any, I know there must be some because I've seen pre-hospital where they move the leads around. But generally speaking, I don't necessarily think it's a good idea, okay, to move the leads around because as long, now let me qualify that a little bit. As long as there is enough criteria on the 12 lead to open up the cath lab, okay, like an inferior STEMI, then what difference does it make to us if there's a posterior STEMI? And so for that reason, I would not take the time, even if I suspected a posterior STEMI, to move the leads around to the back, because I don't think it's worth the time. It doesn't change your treatment if you're going to the cath lab. Okay, does that make sense to everybody?
Mm-hmm.
Good. You could do it on the way in, but I've always thought, yes, what do you do? Sit the patient forward as you're pumping down the road and say, let me put these on the back. You could do that, but I'm not sure it's worth it for us to do it. Okay? I would, however, if I had, when I was giving the HERE report, if I was describing the 12 lead, I would say something like, this patient has ST elevation in 2-3 AVF and reciprocal changes in 1 in AVL, so suspected inferior STEMI, and ST depression in V1 and V2, suspected posterior. I would certainly mention it, but I wouldn't necessarily check myself. So I'm sorry I don't have a handout for this, but I think you can see it well enough. All I want you to go through, and Riley, you're closest, so you can go first, is we're looking in V1 and V2, and if it spills over into V3 and V4, you can mention it. Well, so first of all, do you see an inferior STEMI?
Yes.
Okay, so now you're at least going to be suspicious of a posterior. So you look over to V1 and V2, and do you see ST depression.
I did.
Yeah, and not only that, it's spilled into V3 and V4. And large R waves, remember, you're probably thinking, well, what's large? Well, the truth of the matter is, on a normal 12 lead, there's practically no R wave in V1. So any R wave in V1 and then anything a bit bigger in V2 is considered large. So, yes or no?
Yes.
Yeah, that's considered a large R wave. And then upright T's. So do we have our true circus pony here? So here's, the easiest probably to see in V2. Do you see upright T's?
Yes.
Yeah, okay, so we got it all here, okay.
Doesn't look as circusy as your slide.
Well, I think you have to draw the
Okay.
horse around it. Okay, again, I've already said this, ST depression most significant, large R wave somewhat significant, upright T's least significant. Okay, so Koa, you're next here. First of all, inferior STEMI,
Yes.
okay. ST depression in V1, V2,
Yes.
okay, and large R's. And that would count, they're largest, they're a little bit larger than normal, so, yes.
How did you say to like differentiate if they're large R's?
Well, I would say any R wave in V1 counts as large, because if you go back and you think about, remember what I talked about, even though I said it's not important, you don't have to remember, R wave progression in the V leads. V1 typically has no R wave at all, so really anything there. I mean, these aren't huge, but they're a little bit larger than normal. Okay, and then upright T's. Yeah, and I guess I didn't think those were so large, but I think they actually are. So, okay, and then Grace, the next one, please.
Inferior,
Mm-hmm, good.
and then there's elevation in V5 and V6.
Okay,
Um,
and then ST depression in V1, V2. If you were to, yeah, it's not much, but if you look, say, oh yeah, here's the isoelectric line, it's about a millimeter, so yeah. And then large R waves, largish, I would agree.
upright T's.
Yeah. Okay.
Okay.
Yes, please.
I noticed 12 like this in our homework too. And like,
Okay.
the complexes are like these little teeny dismal things.
Yeah, I agree. They're
What-
kind of dismal.
Yeah, what causes the like,
So what causes that is some kind of, usually it's one of two things. It's either something between the electrode and the heart. So that can be some obesity, it can be pericardial effusion, it can be something that is making it difficult for the electrode to sense. The second thing would be if somebody was, for example, was in heart failure and in really bad heart failure, so the impulse going out is just not very good. So one or the other.
Okay, thank you.
Yep.
A few slides ago, it said that large R's qualify for bigger than the S wave. Are we going
Yeah,
by that?
you can use that. You can use
Or
that.
just the presence? So I was wondering on your last one if that's why you haven't selected it.
Yeah,
but-
I'll say you can use that. Certainly if it is bigger than the S wave, then it counts. The thing is, I hate to, the trouble with rules like that, even though they're useful, is that they sometimes are a little too arbitrary. So definitely if it's larger, yes, but that doesn't necessarily rule out if it's not larger. Okay, okay, Natalie.
I see elevation in 2, 3, and area.
Uh-huh.
So there is an inferior. And then there's a little bit of depression in 1 and definitely V1.
Uh-huh.
Depression in V2. V2 has large R waves. I'd say.
Yeah, so see, again, it's a little bit of a judgment call. And again, in a way, it doesn't matter because we really have to move them around. This one clearly is not large. This one, not too large, Okay.
And then V1 looks like it might have an upright T, but V2 does not.
Yeah, I think that's either a biphasic or a flipped T, it's hard to say. But anyway, we do have ST depression, and again, that's enough to suspect it. Okay, Andrew, you want to do the next, please?
Yeah, let's see guys.
Looks like there is ST depression in V1 and V2. I don't know, they don't look that large, so.
What doesn't look large?
The R waves for V1 and V2.
Oh, I agree, they're not that large, I agree.
But there is upright G waves.
Yeah, hard to see, yeah, so we'll go with that. Okay. Yeah, these are kind of, hard to say what's happening with these T waves. Are they biphasic? There's always a little bit of a rebound when it comes up. Are they inverted? I'm not entirely sure they're upright. Okay, but again, ST depression V1, V2 alone is enough to be suspicious of a posterior. Oh, I guess it's just repeat. Large R waves alone, slightly suspicious. But don't worry, if you see upright, if you have a 12 lead and there's upright T's in V1 and V2, even if there's an inferior STEMI, by itself, that's a meaningless sign. It's just in conjunction. Okay, so here is a, this one's, you can see, okay, so we have our inferior, so we definitely have suspicion of a posterior, and they checked, and sure enough, it is a posterior. So here is a pre-hospital 12 lead where they did check. So this was the initial one. So it's initial pre-hospital with an inferior STEMI and a little bit of lateral involvement. There, not so much on V5. So they actually, first they moved V4 over. So see how they wrote in V4R. So there is no right-sided. But then they moved 5 and 6 to look for the posterior, and it was confirmed. Now, one thing you should know is that when you check for posterior, all you need is a tiny bit of elevation, maybe like half a box. Okay. So again, whether that's worth it, I probably wouldn't do it myself. With one exception, okay, I would move it. Is it possible to have an isolated posterior without inferior and lateral involvement? And the answer is yes. It's pretty rare, because remember I said, oh, it's almost always associated with inferior or lateral or inferior lateral. Here's an example of a confirmed posterior STEMI. And if you look, there's no inferior, there's no lateral. The only possible STEMI on this is the suspected posterior. If this was my patient, I would move the leads around. And again, that's just me, but I would, because it can make the difference between opening up the cath lab and not. Okay? Because based on what you see on the rest of the 12 lead, I doubt very much they would, I mean, there's nothing there to open up the cath lab, but if you moved it around, and apparently this was a confirmed posterior, I don't have the second 12 lead. Here's another one. Same thing, there's no inferior STEMI, no lateral STEMI, but we have this really suspicious, oh look at that, we have suspicious circus ponies in V1, V2, V3, and so that would be a time that I personally would move it around.
It's kind of scary how easy that could be to miss if it was
Yes.
or more subtle.
Yes, well this came out of a little lecture about how these were missed. And not by the paramedics. I mean, they're probably missed by the paramedics too, but by the ED. So, yeah, the thing is you have to look for it. You have to say, okay, I'm all done, but is there anything else? And also, if you're really conscientious about going through all the leads and say, is there elevation, is there depression, without like jumping to conclusions, you get to the end, you say, oh, I've got depression, doesn't mean anything. So
And
that's how you would probably catch it.
Do posterior MIs present the same way as far as patient
Yes,
presentation? Or-
yes, which means all over the map,
Yeah.
right? So, yeah, there's nothing special about the posterior, yeah.
Is there a certain amount of depression that you're looking for before you pull the trigger to do a posterior?
I would say, in this case, at least one box.
Okay.
Okay. It's just a little summary. Oh, I know what that is. Okay, so